All right. Hi, you guys. I am Captain Ferris. That was Elvis. I'm going to be talking to you guys about abdominal emergencies. So big thing with abdominal emergencies is kind of knowing your anatomy, knowing what goes where. So, when somebody comes to you and says, I hurt right here, knowing, well, that is potentially their liver, and if they're saying right here, knowing that's their stomach, or that could be their spleen. Thinking of other problems too. If it's a female, if they're telling you like left lower quad, be thinking possibly ectopic pregnancy. Asking the questions to kind of help sort out what goes where, and think in your head through like what body system are we talking. So a big thing that kind of helps with is like kind of narrowing down your thought process, and thinking about what kind of emergencies you can have based on where they're having pain or where they're having symptoms. A lot of times in nursing school, in medic school and stuff, they divide you up into quadrants, and that's kind of a down and dirty way of giving you general anatomy in that area. A big thing too is that you can divide that down even further, and instead of quadrants, you got more like a tic-tac-toe board, and knowing, if you're talking right here, you could be talking about kidney stones, diverticulitis, constipation. So these things can, go from real bad to, kind of run-of-the-mill stuff. So another consideration with your abdomen is you have a combination of hollow organs and solid organs, and kind of knowing the complications associated with what, and then also kind of knowing what mechanisms tend to impact, what types of injuries these patients present with. One thing is, knowing specifically what are your hollow organs. GI tract is your big one, your bladder, your ureters, your stomach, fallopian tubes. So especially like we talked about in the trauma lecture, things like blast injuries, inside that container where that blast takes place, there could be a superheating of gases as all that energy expands, and it does the exact same thing to you internally. And like with electrical injuries, as that goes through, it can pop stomach, it can pop your GI tract. So those are important kind of considerations to think about too. As far as solid organs, big thing is like your liver or your spleen. Those are big bleeders, but also your kidneys, your pancreas, your adrenals, ovaries. So biggest thing to know is with those solid organs, you tend to worry about massive bleeding. You tend to have referred pain, rigid abdomen, things like that to kind of indicate there could be a potential for some kind of solid organ injury. Another consideration is with abdominal injuries, your abdomen is a compartment, just like your muscles are. There's a set amount of space, and we all know how big a pregnant belly can get. Well, that's not necessarily the case, if it's not expanding over 9 months. When that expansion occurs rapidly, and you tend to have a lot of pressure within that compartment, you tend to run into the same problems that you have with compartment syndrome in a muscle of ischemia. That same thing happens internally when it occurs in the abdomen. Let's get down. Your abdomen, as you would suspect, is highly vascular. The biggest pipeline that you got running right through the middle is your aorta, and all of those perfusing vessels, to your mesentery and to your kidneys, come right off the aorta. So there are some interventions once you get those patients to the hospital. They can take them down to interventional radiology and do things like coiling, where they actually go in and they shut off that little bleeder. They have a device called a Roboa that kind of snakes up through the femoral artery, and just like a Foley catheter, it expands within the aorta, and it essentially cross clamps the aorta. So if you've got massive internal injury, it at least, you know, is kind of shunting the flow of blood back to, you know, your heart and brain, and keeping the essentials perfusing until they can actually get in and open, you know, whatever that vascular emergency is further down. One thing that, you know, we can do from, you know, our like pre-hospital standpoint is something called junctional tourniquet. If you have access to that, it's exactly what it sounds like. It tends to be useful for, you know, abdominal aortic bleeding. I've also heard of it being used, you know, for neck injuries, for axillary injuries, just places that you can't get a tourniquet like an extremity on. You can place a junctional tourniquet, and so that helps with some of the deeper structure bleeding. This, I'm not going to bore you guys with the video, but essentially demonstrates the process of Roboa. And so this is your aortic arch, and so what this doc has is a sheath that goes up in, and like I said, it's just like a Foley, and you know, they'll put it in to kind of block that flow distally to it. That will be included in the slides for you guys. I'll get those out so that you can kind of follow along and watch the videos if you have time. So indicators of internal bleeding, you can have a couple signs. Cullen's sign is just like periumbilical ecchymosis, so just around your umbilicus you'll see sometimes. It's a very late sign, so you don't often see it like in acute post-trauma, but several hours kind of down the road as blood accumulates in the abdominal cavity, sometimes you can have that Cullen sign. It's a big thing that you'll see with like blunt abdominal trauma. Bleeding from aortic rupture, I have seen that kind of down the road after repair. Sometimes you'll see a positive Cullen sign. Occasionally from a ruptured ectopic pregnancy, depending on how long that's been able to go along bleed. Gray-Turner's sign tends to be more indicative of like a retroperitoneal bleed. It's like flank bleeding. So acute pancreatitis, sometimes you'll see that. Ectopic pregnancy, again. Renal injuries, occasionally you'll see Gray-Turner's sign. Another thing that's really interesting is you can have referred pain, and as you have visceral pleura, it's really deep, and so inside of your peritoneum, it's highly innervated, so that you feel the pain kind of through your body, so that you know that there's a problem. But a lot of times, I actually had a friend that got into a car accident, and she had a liver laceration, and she said the shoulder pain, she actually wound up on a PCA, so like a continuous infusion of analgesia, because the referred pain in her shoulder was so severe. She didn't feel anything at all, you know, right upper quad, but it was all referred pain to her shoulder, and she said it was just horrendous. That's why you'll see too with like a heart attack, it'll radiate down the arm. Again, that's, you know, that referred pain. I, let's see, had my appendix out, and you know, it's kind of showing just a general right-sided abdominal pain. You'll get that kind of referred pain. So that is definitely something that you can see. So as far as managing these patients, pain is, again, very significant. So There are a lot of pharmacological interventions. Opiates tend to work really good on deep visceral pain, such as these patients would be experiencing. The only problem is it is a vicious cycle, and as you slow the GI tract down with opiates, obviously your motility slows down, they start getting constipated. The constipation from opiate medications can be significant. It can be really, really severe. So a lot of times, you'll see docs trying to manage it more with like antispasmodics. So for like IBS and stuff like that, you'll see them prescribe something called Bentyl in like a hospital situation, because the opiates just kind of compound the problem. NSAIDs also are the devil in these GI kind of complaint patients. Yes, it decreases inflammation, but at the same time, it kind of decreases like the stomach lining's ability to produce a mucus layer. So it contributes to erosions and stuff. And so that's why, taking 800 milligrams of Motrin every 6 hours every day of your life, may make your knee feel better. It can cause, significant problems with your stomach. So one thing that we can do for our patients is, at the very least, control their nausea. Nothing's worse than being in pain and nauseous. And talking to oncology patients, a lot of times they'll say, like, I can deal with the pain, I can't deal with the nausea. And it can be really, really crushing and debilitating. And as the stomach kind of spasms down, it just kind of compounds the pain. So there's a lot of different ways that you can manage nausea. Antiemetics are obviously a good way to do that. Cannabinoids have good effects. In some cases, there's a drug that we will give to oncology patients called Marinol that works really, really well for nausea. And it's, based on cannabinoid. You can actually have, in the case of, certain disease processes, you can have something called cyclic vomiting syndrome, where you get started vomiting and it like triggers this kind of feedback loop, and it just keeps going and going and going. And those kind of loops are best managed with anxiolytics. Actually, it kind of helps to decrease, that constant cycle of just, vomiting. So Ativan, a lot of times I've seen Haldol given. So big thing is, if they have something available to them for nausea, go ahead and give it. So another big thing is kind of decreasing the amount of pressure in the compartment. So as stuff expands and begins causing pain, it's a good idea, if there's no contraindication, like oral maxillofacial trauma, you want to try to get an NG tube in these patients. But beware, this is probably a DOP-off tube, it's not necessarily an NG tube, but this patient evidently had a defect in his cranial vault, probably from a basilar skull fracture, and you can see this coil up into his brain. So if there's any kind of indication of facial trauma, don't put one of these in. You can let the doc deal with that. Absolute contraindications to placing an NG tube, again, oral maxillofacial trauma, a Lefort fracture, anybody that, after facial trauma, you can see in these Lefort fractures, there's like a mid-face instability, and they'll be talking to you, and it's almost like they've got a loose set of dentures in place, and it's actually like that section of their mid-face has come off, and it's just kind of floating there. So do not put an NG tube in that patient. Basilar skull fractures, cribriform palate fractures, esophageal varices. So if somebody has like a history of significant alcoholism, chances are they have some varices in their esophagus, and it's almost like varicose veins that you see in like old ladies' legs. it's the same thing but on the inside, and it's pretty easy to pop one of those guys by dropping an NG tube, so it's a good question to ask. Another thing too is recurrent posterior nosebleeds. So patients that tend to get nosebleeds where it drips in the back of their throat, you can kind of exacerbate that, and I've actually seen a posterior nosebleed prove to be fatal in the past, so it's always a good thing to ask. So again, this sort of goes back to our trauma lecture. Any kind of indication of like a basilar skull fracture, avoid putting in a NG tube at all costs. So skull deformity, raccoon eyes, halo sign, that battle sign behind the ear would be a reason to forego an NG tube for sure. One thing that I wanted to talk to you guys about is, putting in an NG seems pretty straightforward, but you have all these little turbinates, and they're just kind of, it's almost like honeybees have like these kind of lobes to their hives. It almost looks like that on the inside of the sinus. And what I want to point out to you guys is kind of that triangle shape of the sinus vault in there. What you want to try to do when you're placing an NG tube is you want to kind of rock the tip of the nose up like a little pig nose, so that you have a straight shot to come straight across that bottom, so that you're not aiming at these turbinates. So again, that's going to help prevent bleeding, and it's just going to make passing it that much easier. So just aim straight. Another consideration too is if you ever have an intubated patient, it's always a good idea to place an OG tube. So you can kind of ride it right alongside the ET tube, and just with the balloon and the obstructive nature of the ET tube. These tend to be pretty easy to place once the ET tube is in there. But you just kind of want to do a straight shot. Reason being, if that patient has been bagged considerably prior to intubation, you get this whole gastric insufflation where they're basically bagging into the stomach, and that stomach has expanded, and again, it puts pressure on the abdominal cavity compartment, and so whatever you can do to kind of decompress that will prevent vomiting and aspiration, and just overall decrease the amount of pressure inside the abdomen. So one of the things that they teach you, in paramedic school is last oral intake is kind of one of those assessment findings that you want to do on your intake assessment. Reason why that's important is because, it gives you a good kind of indication of like what's going on with the patient. When was their last oral intake? When was their last bowel movement? When was their last menstrual period? And never trust anybody when they tell you their last menstrual period, unless they're showing you the app and specifically where they put it in. A lot of times it tends to be off pretty considerably. One thing to talk about that's a risk factor for females of childbearing age is ectopic pregnancy. These can be sudden hemorrhagic emergencies. They occur when a pregnancy takes place somewhere not in the uterus. Typically it will happen in the fallopian tube. If a female has a history of pelvic inflammatory disease, it can irritate the that kind of inner lining of the fallopian tube and cause the embryo to get stuck on the way down. Also, if she's got a history of abortion, when they go in and D&C the inside of that uterus, a lot of times it can kind of cause scarring around the opening and cause, embryo to get stuck kind of on the way down. If those rupture, those fallopian tubes are so highly vascular, these women can bleed out really precipitously, and it can be pretty significant. And then this is my favorite because I hate my little appendix. He tried to kill me. So Right lower quad pain, you always want to ask, like, do you still have an appendix? So that's an important question. And one kind of thing is rebound tenderness, abdominal rigidity. A lot of times they'll have a lot of nausea, vomiting, super high fever, but that's that guy. All right, you guys, that's kind of it for abdominal emergencies, short and sweet. Just keep those thoughts in mind as you assess your patients. Thanks.